This is Andrea Kane, and I am here with you on Chapter 8. We are talking about HIT 292, healthcare reimbursement. We are on week 11, and turns out Chapter 8 actually has 4 PowerPoints that go with it. So you will have a total of 6 this week. You will have 2 from Chapter 6, which are done and should be posted now for you. And you will have the 4 for post-acute prospective payment, and those are coming up, and this is number 3 of the 6. So we'll have 3, 4, 5, and 6 coming up. All right, so chapter 6 was about inpatient prospective payment. Inpatient for acute care facilities and inpatient for psychiatric facilities. Now we're moving to the post-acute side of life. So the first one I'm going to be talking about is skilled nursing facilities or long-term care facilities. Nursing homes is typically what it is. Then the next video will be on long-term care hospitals and their prospective payment system. And then the next one after that is can you guess? Have you guessed yet? Rehab facilities. And then after rehab facilities, we'll talk about home health care. So they all have prospective payment systems, and we'll be covering those. All right, so we are on Chapter 8 now. There are 4 videos and PowerPoints that go with Chapter 8 because we're doing post-acute care. If you are thinking about unit objectives, if you look at your syllabus, they are listed there. If you're looking at learning objectives according to the book, it is here on the screen. We're looking at Medicare's all-inclusive per diem rate for skilled nursing facilities, or SNFs, SNFs. We'll talk about the specialized collection instruments that exist in post-acute care, the classification models and payment formulae associated with reimbursement under Medicare and Medicaid's PPS systems for post-acute care. So one of the first things that they're going to do here is they're going to talk about some key terms. And when it comes to key terms, I am a big believer in flashcards and in looking in the back of your book. So that is going to be one of the things that I encourage you is that you go to Appendix A, or the glossary. It starts on page 307 in the back of your book. You should be able to find all of these terms back there, and they'll be listed with their definition. And I would make sure that you are familiar with all of those. We'll also run across them in our book as we go through. Chapter 8 starts on page 195, so you'll see them as you go through. But I would also remind you, you've got the glossary in the back in Appendix A, so utilize it. So these are all the terms that you're going to need to know. And I will tell you that you will see a lot of these on your quiz. You'll see SNF, you'll see MDS, you'll see ADLs, and RUG for sure. Not sure about the others at this point, but you never know. Always good to know these things. So let's talk about post-acute care. That's where you're providing patients with healthcare services for their recuperation and rehabilitation after an illness or injury. There are 4 settings that are known as post-acute care. And we're going to go through the prospective payment systems for all of those. Skilled nursing facilities, SNFs, which is what this video and PowerPoint is about. Then long-term care hospitals, or LTACs. Inpatient rehab facilities, IRFs, and home health agencies, HHAs. Those are the 4 that are considered post-acute care, and those all have prospective payment systems in them. And this just goes on to talk about how Medicare wants to ensure beneficiaries receive appropriate high-quality care in the least costly settings appropriate for their clinical conditions. That's really what they're trying to do. They want safe, continuing recovery in settings that are less intensive and more appropriate than acute care inpatient hospitals. All right, so what is similar about all of these? Well, they all are required to collect and report data. It is all based on a classification system. Their base rate converts to a relative weight to dollars. There is a geographic adjustment for cost of labor, just as we learned about the other prospective payment systems, and provisions and adjustments for patients with atypical characteristics and facilities with special situations are permitted. So again, I talked about we are starting on page 196 in your book and moving forward from there. You need to know that the impact or Improving Medicare Post-Acute Transformation Act of 2014 is what really brought into being the prospective payment system for post-acute care. And it required PAC providers to report standardized patient assessment data, standardized quality measures, and resource use measures. And then, of course, CMS continues to modify data collection tools. So let's talk about skilled nursing facilities by themselves. And I apologize for my voice. I have been recording lectures today more than I usually do, and I also had a live class. So if my voice starts getting kind of crackly, I apologize for that, but I really want to get these lectures to you so that you have them. So I may stop a little bit and take a sip of iced tea here now and again. Nursing homes are licensed by states, and each state has somewhat different requirements. However, there are federal conditions of participation rules that govern some things. But nursing homes are a healthcare facility licensed by their state. They offer 24-hour per day skilled nursing care and personal care services. A skilled nursing facility also provides short-term skilled nursing care and rehab services to beneficiaries after an acute care inpatient hospitalization. So you can have a nursing home that does not do skilled nursing facility services, and you can have a nursing home that does. Make sure that you know what these definitions are. They are slightly different. Most skilled nursing facilities provide both, but some nursing homes don't provide skilled nursing facility services. It just depends. So what are the basic concepts? Well, the first thing is activities of daily living. And the definition for that is basic personal activities that include bathing, eating, dressing, mobility, transferring from bed to chair, and using the toilet. Activities of daily living are used to measure how dependent a person may be on requiring assistance in performing any or all of these activities. Personal care services. That is assistance with activities of daily living, self-administration of medications, and preparation of special diets. Personal care services may be expanded to include light housekeeping furnished to an individual who is not an inpatient or a resident of a group home, assisted living facility, or long-term facility such as a hospital, nursing facility, intermediate care facility for the mentally challenged, or institution for mental disease. Personal care, also called custodial care services, are those that individuals would typically accomplish themselves if they did not have a disability. So make sure you know the difference between ADLs and personal care services. Rehab services are services designed to improve or restore a person's functioning, including physical therapy, occupational therapy, or speech therapy, or some combination of these. Skilled care is defined as, let me go back here. Skilled care is defined as level of care such as injections, catheterizations, and dressing changes provided by trained medical professionals such as physicians, nurses, and physical therapists. So skilled nursing care is daily nursing and rehabilitative care that can be performed only by or under the supervision of skilled medical personnel. All right, so let's go back to nursing home versus skilled nursing facility for a moment. A nursing home is a facility that's licensed by the state to offer residents personal care, and we define what personal care, as well as skilled nursing care, which we also defined, 24 hours a day. Provides nursing care, personal care, room and board, supervision, medication, therapies, and rehabilitation. Shared rooms and communal dining rooms are common. They may be licensed as nursing homes, county homes, or nursing homes residential care facilities. That is a nursing home. Now listen to the definition for skilled nursing facility. It is a facility that is certified by Medicare to provide 24-hour skilled nursing care and rehabilitative services in addition to other medical services. That is the difference. This is all in figure 8.1 at the top of page 197 in your book. Please make sure that you are very familiar with those 7 basic concepts. Make sure that you know those differences and have those clear in your mind. You will need that. Okay, so we covered this. Sites of SNFs. There are freestanding facilities, and that's the vast majority of stays. There are some hospital-based units. I've worked for facilities that had hospital-based SNF units. Most of those have been phased out. There are a few left here and there. A lot of acute care hospitals have moved to swing beds, especially in rural or areas or critical access hospitals. A swing bed is a bed that can be used for inpatient acute care and then as well as skilled nursing care, but you swing the bed. So let's say for days 1 through 3 of the patient's stay in a small rural hospital or critical access hospital, they would be receiving inpatient acute care. Then on day 4, they would have been discharged to a skilled nursing facility. They're allowed to swing that bed and start providing skilled nursing care without the patient changing the bed or changing the room. But it becomes billed differently. And the services provided change with that definition as well. So reimbursement methodology. Let's see here. In case you're wondering, I am now, where in the world am I now? I'm trying to keep up with this so that if you're going through your book with me, you're staying on course. I'm not seeing where it has swing beds, but I'm sure it's here. But I'm moving on to page 198, where we're talking about payment, per diem payment. But I don't want to skip here where it talks about consolidated billing and minimum data set, because those are important. And I'm not sure. Okay, so we're going to do reimbursement methodology, and then we'll move into consolidated billing. All right, works for me. Got it. So, all right, per diem payment. This includes all costs that facilities would be expected to incur when they provide SNF services. So it includes skilled nursing care, rehab services, ancillary services. Those are all operating costs. Then you have capital costs. Think of capital as being the building, the facility, the bed, the room, the heating, the cooling, all the electricity. Those are all capital costs. Well, they may also blend into operating, but they have to do with the overall provision of the site itself. And then there's other goods and services. So that's all the operating costs, capital costs, and other goods and services are all part of that per diem payment. Now, they do exclude high cost, low probability services. Those are reimbursable separately. So again, you're just looking at the normal costs that most SNF facilities would provide when it falls under operating, capital, and other goods and services. Consolidated billing requires the SNF to pay for outpatient services that a resident may receive from a vendor. Examples are lab tests, x-rays, pharmacy meds, It does not include, meaning it excludes emergency medical services, inpatient services, extensive procedures, and certain high-cost, low-probability ancillary services. So consolidated billing is that the SNF is going to pay for those. So an outside vendor who provides services to SNF residents with Part A benefits submit their bills to the SNF, not to Medicare. So if a nursing home resident has a lab test, the lab that is contracted to do that test, they submit their bill to the SNF, not to Medicare. That's what consolidated billing means. So Medicare only receives a bill from the SNF. They don't receive a bill from the lab, a bill from the radiology service, a bill from the pharmacy service, all of that. But if the patient does receive emergency medical services, Medicare will receive a separate bill for that. Hopefully that makes sense. All right, data collection tool is the MDS 3.0. So make sure that you are familiar with the MDS, minimum data set. You've got to know MDS means skilled nursing facility. It means minimum data set. It is the clinical documentation of the resident's care. Clinical data. Please know clinical data and MDS go together. It is not claims data, it is clinical data. And it has to do with the resident's care. Think about that. Resident's care, not their diagnosis, their care. The MDS becomes part of the permanent health record. Excuse me. Like I said, I guess I've talked a little too much. My apologies. I guess you can tell that I'm not used to talking quite so much for quite so long. All right, so there are schedules of assessment specifically for the start of therapy, change of therapy, end of therapy. End of therapy with resumption, significant change in status assessment, and significant correction to prior comprehensive assessment. All of those have to be done within certain time frames that are mandated by CMS. They can be reported together and combined, but they have to be done. And the specific data elements required by CMS have to be addressed. So, structure of payment for SNF prospective payment system. There's a base rate, the SNF classification system, and then of course adjustments. And where you'll see this is at the bottom of page 198. So there is a base rate, a per diem base rate for SNF PPS. And that is for each day of care. The daily rate is known as the federal base rate or the federal per diem. And that is calculated using allowable costs from previous SNF cost reports. Remember those Medicare cost reports we were talking about? Yep. They have to be submitted to Medicare every year within 5 months of the end of the fiscal year. And then to calculate the base rate, CMS typically uses the most recent year for which it has complete and available data. So what adjustments are applied to the base rate? There are geographic factors and inflation. There are some that are mandated by statute or regulation. If we look, and there's also patient resource consumption, complexity, and resource intensity of residents' conditions. So make sure you know the 3 adjustments to base rate for SNF PPS are geographic factors and inflation, anything that's mandated by statute or regulation, and patient resource consumption. If you look at the top of page 199, there you go with the skilled nursing facility PPS. Step 1, adjustment for geographic factors. Step 2, adjustment for case mix. That is that patient resource consumption. Step 3, you calculate the payment. Because you have to figure out the number of days of the resident's stay. And of course, the base rate is annually adjusted for differences in local markets and in different geographic areas because the costs are different. Moving on to RUGs. Anytime you see RUGs, you need to think skilled nursing facility. RUGs, MDS, and SNFs, they go together. So RUGs are, the definition that they give here is that they categorize residents into groups based on their functional status and expected resource consumption. So make sure you know the definition that RUGs are resource utilization groups. They categorize residents into groups based on their functional status and expected resource consumption or resource intensity. There's a nursing component, a therapy component, and a non-case mix adjusted component. You need to know all three of those. Make sure you're familiar with those. Hint, 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 hint. The definitions for those are in figure 8.3 at the top of page 200. So make sure you take a look at that. You need to know what the index is versus the component versus the amount for all of those. And those are all listed. So make sure you study figure 8.3. On page 201, they give you an example of the RUG classification system, and they give you the category, the rehab level, the ADL levels, extensive services. And so you can see how they move through that to determine what RUG they fall into. And then from RUGs, then you look at your labor, your wage index, your adjusted labor, non-labor, adjusted rate, Medicare days, and get to your payment. Now, I'm not going to ask you to figure out what a payment is, but you just need to know, again, the components that go into it. And that's all on page 202. So there are 66 RUGs. RUGs is in its fourth iteration. That's what RUGs IV stands for, is RUGs 4. There's 66 of those. There's 52 upper groups and 14 lower groups. The 52 upper groups typically require skilled or extensive services. The 14 lower groups typically don't require any skilled services. So this is a visual here of the 66 and how they break down. When you look at the 52 upper groups, they're looking at the ones that involve rehab, extensive services, special care, high, special care, low, and clinically complex. This is sort of the DRG or MSDRG version for SNFs, except remember, this is all about resource consumption. This is all about how intense are the services that residents are receiving. And then this looks at the lower groups. This is more about reduced physical function or symptoms and cognitive performance, behavior, cognitive type issues. So it takes into consideration total therapy minutes. So if you're thinking documentation, immediately mind goes to documentation. What do you need to know? You've got to know how many minutes they're spending with a patient doing therapy. That's got to be documented every single time, every single therapy. Type of therapy, number of days in the therapy, the mode of therapy, presence of conditions and diagnoses, if they have a tracheostomy or if they're on a vent. Their ADL score. You need to know how many of their ADLs they can do by themselves versus how many ADLs are having to be done by others. Can they do their ADLs or can they not? Then reimbursement looks at the per diem rate for the RUG. It's wage index adjusted to create the adjusted per diem rate. And that rate is multiplied by the number of Medicare days, the length of stay, to determine the reimbursement amount. And again, this is all on page 202 in your book. All right, so we made it to the end of that one. I will be back shortly with the last three, and that will be long-term care hospital prospective payment system, and then rehab, inpatient rehab, and then the last will be home health. So enjoy, and I will talk to you again soon.